Good afternoon, everybody, and good morning. We will be starting our webinar shortly. This is our second series of COVID-19 for health centers, and we'll get started in just a moment. Thank you. Good morning, everybody. Our webinar will be starting shortly. We want to thank our healthcare heroes who are on the front line of fighting the COVID at our community health centers. We'll be starting the webinar in just a minute. We will be having some participation from the audience with question and answers. So you can put in your question in the chat once we start, and hopefully we will get to as many questions as we can towards the end of the session. We'll be starting momentarily. Thank you. So welcome, everybody. We will be starting our webinar in about 5 minutes, preparing communities for COVID-19. This session will be focusing on telehealth, and we'll be hearing from our partners at community health centers across the country. So please join us in 5 minutes. We will be having some polling questions and also a Q&A session. So please be able to put your name and your health center along with your simple question within the chat, and hopefully we'll be able to get to all of those questions. The webinar will be starting shortly. Good morning, everyone. The webinar will be starting in 2 minutes. Preparing Communities for COVID-19, Session 2. We'll be hearing from our community health center partners from across the country and also understand how they have stood up telehealth. Webinar will be starting in 2 minutes. Thank you. The webinar will be starting in 1 minute. We have approximately about 120 individuals joining so far. Let's give it a couple seconds more, and we'll be starting our webinar. We want to be thankful for our community healthcare heroes who are proudly standing behind health centers on the front line to help fight COVID-19. The webinar will be starting in about 30 seconds. So hello, everybody, and welcome to Preparing Communities for COVID-19. This is our second session in a series of hopefully weekly sessions focused on community health centers' response across the country. Thank you. My name is Tim Long, and I serve as the Chief Clinical Officer for both Health Choice Network and Alliance Chicago. Today, we have a very packed agenda focusing on the community health centers' response to COVID-19 with a special focus on telehealth. Our agenda today is going to center around some words from our CEO at Health Choice Network, Alex Romeo, and also our CEO at Alliance Chicago. Then we will move into a perspective from New York and New York City and state with our colleague seeing patients there in New York. Then we're going to hear directly from 3 health centers across the country. They will give us their individual health center experience on standing up telehealth in this period of COVID and what their good and bad challenges have been. And hopefully we can learn from those 3 health center experiences. Then we will move into and hear from our partners at Finger Lakes in New York. They have done years of experience in sustaining telehealth, and they will help us walk through some items that we can take from today's lesson and moving forward into beyond COVID-19 and how we can continue to use telehealth to advance technology and healthcare within community health centers. Then we will hear from some of our staff at both Health Choice Network and Alliance Chicago and some resource guides that we have put together for your use at your health center on telehealth. We hope that this session will be very interactive. We will also be having some polling questions towards the end, but more importantly, if you do have a question of any of the speakers, please type that into the chat. Please put your name, your health center, and your focused question, and we have people who are looking at the chat box throughout the session. So first, I'm going to turn it over to Alex Romeo, who is the CEO of Health Choice Network. Alex.
Good morning, everyone. Thank you, Dr. Long. I appreciate your leadership and time you put into gathering all the troops so we can learn from each other and share best practices. I wanted to first recognize all the health center leaders, our healthcare heroes, as we deemed for your work and your endless time and effort and caring compassion during this very difficult time. When I hear about the front lines, I can only imagine the work of your staff, your boards, and all your partners are putting into this effort, and we recognize that, which is why Health Choice Network has pivoted very quickly to be able to support your efforts via three overarching goals. The first is make sure you have the systems, technology, and data being collected, so that way we can tell this story and make sure that your needs are being reported all the way up to the HHS level and working with independent PCAs at each state. We have found ourselves yelling and screaming with legislators on the phone trying to represent what's actually happening on the front line. So we thank you for continuing to give us that information and allowing us to serve as your sounding board. I can tell you the second major focus for us has been making sure that the reimbursement models and the ability to weather this storm financially are at the top of our list. We've been working very diligently, 24 hours, 7 days a week shifts to work with anyone that is willing to listen and to work with us on the coding, the virtual meetings, the remote monitoring, telehealth, and also the phone consultations. So we thank you for your efforts and sharing those best practices. We are now monitoring our RCM process to make sure the work you're doing is actually being paid as per the guidance from CMS. And lastly, but certainly not least, is to offer all our support via our staff, volunteering, and we've served as a logistical standpoint for PPEs. We have been on the phone at 3 in the morning with China. We've done everything we can to make sure that you have the supplies that you need. We know, and we're hearing from the front lines, supplying is getting low, and in some cases has not yet arrived. We are working with individual states, individual distributors like McKesson, Direct Relief, MAC, HRSA, the Bureau, you name it, anyone that will listen, including legislators. So our focus today and ongoing is to make sure we support you during these efforts and allow you to see the patients and allow us to be able to lift some of that burden. I want to thank all of you once again, Dr. Long, and the endless hours the team has put together. And I always remember Betsy Cook, our founding CEO, of telling me why the network was formed. I appreciate this more than ever, being here 20 years now, to see that vision and that mission being lived out daily, because this is why we were formed, is to work together as not a network of systems and technology, but as a network of family and partners to serve our communities. Thank you, Dr. Long. Look forward to hearing from the other panelists.
Thank you, Alex, for those words, and thank you for your leadership during this time. Next, let's turn it over to Dr. Fred Rockman, the CEO of Alliance Chicago. Fred, are you with us?
Yes, I am. Thank you, Tim. I just want to build briefly on what Alex said so we can get to the meat of today's call. You know, Alliance Chicago and Health Choice Network were founded by groups of health centers recognizing the power of sharing approaches and resources to advance our work. And together we have done amazing things. The pandemic has forced you all to rapidly push the envelope of how we think about caring for our patients. We at the networks are inspired and energized at the opportunity we have on today's call to compare notes and learn from each other as we continue to identify at Alliance and Health Choice ways that common resources and additional expertise can help you go faster, farther, smarter. We are determined to help you emerge from this crisis, which will end having made lasting advancements. With that, I really just want to turn things back over and open the opportunity to hear about exciting work that you all are doing. Thanks, Tim.
Great. Thank you, Dr. Rockman, for those words of encouragement. So our first speaker is coming to us from New York. We thought it would be very helpful to hear the actual words of a chief medical officer whose health center is within New York City, and our colleague, Dr. Warrior Esmond. Dr. Esmond, are you with us?
I am, Tim. Thank you. So good afternoon, everyone. And as you're hearing on the news, I'm sure New York City, New York State, and New York City are the epicenter of this epidemic in the United States right now. As of this morning, we had 75,000 cases across the state, with about 41,000 of those being in New York City proper. So we are definitely being challenged. Historically, we saw COVID emerge in early March with one index patient who quickly infected 22 other individuals. It was hard to believe, but very soon after that, we were now dealing with a community transmission issue. On March 9th, there were 25 cases in New York State, all related to that one index patient in Westchester. And hearing this, we made a business decision at Settlement to look at retraining on PPE, as well as reviewing the clinical guidelines for COVID at our upcoming March 11th staff meeting. Well, the best laid plans of mice and men, our first patient under investigation walked through our doors on the evening of March 10th. The good news is he ended up testing negative, but he met several of the criteria for being considered as a potential COVID patient. Within 1 week of that patient, and thank goodness for our training, we were seeing a consistent stream of patients, 2 to 3 per day with symptoms and risk factors, which at the time still included travel as a primary risk. Labs were beginning to stand up testing for the community, and we were able to refer our patients out to local urgent care for the testing, as our lab was unable to meet the demand for supplies. We then learned early on in that week that the state was reporting potential issue in their ability to run the test due to a shortage of reagents. On March 20th, all ambulatory care in New York City was mandated to cease testing in the ambulatory setting due to the shortage of personal protective equipment that we were experiencing across the healthcare industry in New York City. In our coming days, Settlement, as well as many of our New York City colleagues, were beginning to see many patients who were positive, and several had reported that they already had positive staff members amongst their ranks. We then transitioned quickly to a presumptive diagnosis for COVID, letting go of testing and assuming that patients presenting with fever and cough were probably COVID positive, and we would send them home with the appropriate measures. We sent several patients to the hospital with significant respiratory distress, and were ultimately able to confirm how to categorize patients and know who we were most concerned about. Anyone with a PO2 less than 94 on a pulse oximetry, we were sending to the hospitals because they were clearly at risk for respiratory distress. Around the same time, New York State approved Medicaid payments for telephone encounters, and us, as well as many of our colleagues, moved to screening schedules and really trying to prevent as many patients as possible from walking through our doors by offering telephone encounters, while we were working to rapidly implement a telehealth solution. Today, we have staggered schedules that allow our clinical staff, our medical providers, as well as our behavioral health and care management staff to work remotely several days a week, keeping a skeleton crew on site for patients who are presenting for care. We reevaluate the schedule on a regular basis and adjust for shifts in patient demand. A week or two ago, we were struggling with managing the sick patient surge that we were seeing at our doors. We were able to create a sick unit where all of our patients presenting for walk-in visits were seen. We then moved to screening every individual walking through the door for fever and symptoms, which was really the single best measure we could have implemented to stem the tide. As of today, we're still challenged. As you're hearing across the country, personal protective equipment is in short supply. Our hospital partners are clearly struggling in New York City, and we have yet to receive any supplies from our any personal protective equipment from our vendors, nor from our Office of Emergency Management, which is the alternate route with which we're able to request personal protective equipment. We have had success with organizations like Direct Relief, and if I have to make one recommendation for those of you who are preparing for what we're experiencing, I would recommend you definitely sign up with Direct Relief and it's such other organizations to begin to set those channels in motion for your personal protective equipment. Our staff are anxious and we're doing our best to reassure them. I send out a weekly update on what we're doing inside the health centers, what is the status of recommendations for patients who have been diagnosed with COVID. We have had our staff exposures and we currently have staff who are out with presumed COVID. We had to make a decision earlier on this week about closing our nearby site to consolidate staff and be able to provide care adequately in one location. In New York, you have to apply to the state to close that site, and we went ahead with that paperwork and we're successful at that. As we're all experiencing, whether you're in the epicenter or not, I'm hearing from colleagues around the country that all of our visit volumes are way down. We're hearing across New York City, 80% of our visit volume is no longer coming through our doors or being a part of our phone encounters. And many of us are facing potential furloughs for staff. Our leadership and our primary care association are working very feverishly, as is I'm hearing Health Choice Network, to really identify opportunities to improve our funding stream so that we're able to keep our doors open and our staff in place. For those of you who are in our less affected communities, we're going to talk about it today, but if you've not started on the journey, it's my recommendation that you move to a telehealth implementation as soon as possible, and very quickly after successfully implementing, look at how you can engage your patients who have not been through your doors or are afraid to come through your doors. We're looking at messaging on our portal, messaging on our website. We're sending out text messages to patients to let them know that we've got video and telephone capacity for visits so they don't have to be afraid about needing to walk through our doors. Make sure that your staff is trained on personal protective equipment use. Keep a close eye on your supplies, and I recommend that you might want to take a look at a tool that NAC has developed. It's called the PPE Burn Rate Calculator. It requires that you keep a daily inventory on your personal protective equipment, and it will help you identify at what point you're in jeopardy of needing to make decisions about staffing and organizational closure, even if you're lacking appropriate equipment. We also very early on decided to utilize our emergency management structure and activate our emergency operations center. We meet daily. We have a daily operations meeting to look at where our gaps are and where we need to change. And I would recommend you start that sooner than later, because most of us know it's not a habit that we're accustomed to, even if you're only meeting for 5 minutes. One thing that has come up in our conversations with our health centers across New York City is really look at our role after discharge for our patients and the patients in our communities. There's literature suggesting that discharged patients are going to need a different type of care than we're accustomed to providing, and we are in the process in New York of convening a group to reimagine what that might look like for our patients on the other side. What are our community challenges? We have EMS is overburdened in our city. So health centers across New York are looking to see what they can do to support EMS by providing telehealth services and potentially being a diversion site for low-risk, non-COVID patients in our health centers. Hospitals are desperate for staffing, and so we're looking at if we have to furlough providers, can we identify employment opportunities for them in the hospital system to allow them to be functional and to maintain an income? And we also are very clear and make clear statements about the importance of our role in the community to prevent patients from needing to utilize the emergency room because of the continuous ongoing primary and preventive care that we're able to provide. So that's our story as of today, and I'm sure there'll be more to come in the near future.
Great. Thank you, Gloria, for those words from Settlement Health in New York. Our thoughts and prayers are all with you and with your health center and with the state of New York. We do have one question that came in the chat that I'd like to ask you, or if we can. There were a number, but we'll just ask you one question now, and I'll read it to you if possible. When you have a presumptive patient, was there guidance from the Department of Health to report the person to the Department of Health?
So we made that assumption with our first PUI, and they were not terribly interested in hearing about the patient. What I did was implement an internal tracking tool. One, because I needed to see what we were seeing. We quickly abandoned that as the numbers started to rise. The other thing I needed to be able to do was to identify the contacts to that patient should they end up being COVID positive, and then having to counsel them. So that was my real internal tracking tool's value for that. But the Department of Health in New York City quickly realized they were unable to manage the volume of reporting that was necessary or thought about.
Great. Thank you very much, Dr. Esmond. Next, we're going to turn to our 3 health center partners. Each of them will give their own perspective on how they, at their health center, have quickly stood up telehealth to help see the patients at their health center. So first, we're going to hear from our colleague, Dr. Doug Rayner from Family Health Network of Central New York. Doug, are you with us?
I am. Thanks, Tim. We are a health center in rural upstate New York. We have not seen the numbers that the city has seen, but we are seeing positive patients, and we're expecting a surge in about 2 weeks for our own area, which is a little different from downstate New York. I'd like to just talk about the timeline that we saw for ourselves. We had a provider meeting back on March 17th. We had not seen any activity of COVID in our area at that point, but we decided that we needed to start rescheduling the patients from their regular routine appointments. These are patients that were deemed high risk, those over the age of 60, those with underlying conditions. And what we found is when we went through this rescheduling, our schedules became very, very blank. And so we identified that in order for us to really, 1, survive as a health center, and 2, to provide care to a lot of our patients, we had to quickly identify a telehealth platform and start working with it. This was basically a situation of flying the plane while we're building it. So our IT team literally Googled telehealth, HIPAA compliant, and they came up with a few choices, and we eventually settled on DoxyMe. One of the advantages of DoxyMe is that there are no add-ons, no plugins, et cetera, so it was really very quick to get started. And so we tried it out a couple days later and saw that it was quite easy to use. And then by that Friday, March 20th, all our providers were trained on DoxyMe and they received accounts. This really involved about a 10-minute session with our IT department staff to really get them used to it. And it was very easy to pick up. And so we created our first telehealth workflow on that date. We've since gone through 2 more versions of our telehealth workflow. So about every 2 or 3 days, we are changing it, which has created an issue with communication, which I'll talk about in a little bit. So we started telehealth that Monday, and our initial criteria for the telehealth visits is looking for patients over 60. We decided our mental health visits could basically all go to telehealth, and then patients with underlying conditions that have them at greater risk for severe COVID disease. We found, though, that we still were not addressing a lot of our patients, and a lot of our patients were just not being seen. We developed a new workflow that addressed some of the insurance coverage issues that we initially were looking at, and we're finding that almost on the hour we had more and more of our payers participating in reimbursing for telehealth. And then we changed our criteria and basically said most visits are going to be eligible for telehealth, and we decided that we wanted to bring in kids for well childs less than 24 months because we wanted to be able to do that weights and measurements and developmental assessments as well as immunizations, and that time period is so critical. We also were seeing our prenatal visits and any visits that have procedures that could not wait. If there are elective procedures that could wait, we're pushing them out, but then other procedures that really needed to be done on a timely basis, we said, come on in. And then we had a new workflow a couple of days later. At that point, up until that point, it was all provider driven with a telehealth visits, but then we included a prep phone call that involved either the MA or the LPN working with a provider. The purpose of the phone call was to verify the contact information, because sometimes we wouldn't have a correct phone number, which is how we would contact the patient, and or the correct email address. The MA would coach the patient about etiquette for telehealth, particularly making sure they were in a secure area that was private. We're trying to maintain confidentiality. And then the MA would go through the various health screenings that are typically found in the intake form, such as depression screening, anxiety screening, tobacco usage, alcohol and drug use, those sorts of things. That really was an MA function in our previous workflow for face-to-face patients, and so we added that as well. Our telehealth workflow, at this point, the MA starts the initial prep phone call, does the screening questions, documents the chief complaint, reviews allergies and medications. There should be a new slide for this, actually, if you want to advance it. And then the MA will let them know that they'll be getting an invitation from the provider shortly. Typically, the patient will either access by either laptop or cell phone. Most of the time it's cell phone. The patient will get an invitation on their phone. All they have to do is open that invitation up. They click allow. That allows us to access their video and audio, and then they go into the quote waiting room, waiting for the provider to get to them. And so the provider can see that the patient is in the queue waiting to be seen. If for some reason there are some technical glitches, we're converting those visits into a telephone visit. Before all this happens, we've identified the patient that is appropriate for the telehealth visit. What we're doing also within the telehealth visit is we developed a quick text that documents consent. We've been advised that we should have at least verbal consent for this. And so there's a quick text that makes it real easy. If a patient is a potential COVID-19 case, we're using the COVID-19 form that has been supplied by Alliance of Chicago. And then if they're a PUI and it's assessed that they are a candidate for testing, that order will be made. And typically at this point, almost all of our COVID-19 testing is being done in our drive-through, which we also started on March 23rd. We're finding that by doing our testing that way, we're minimizing exposure to staff and patients of potential COVID patients. And we're also conserving PPE, as we have 2 staff members that have the same set of PPE as they're manning the drive-through. And right now we're testing between 5 and 10 patients a day. When the visit is complete, provider closes the telehealth visit, hangs up. The visit, once it's closed, it's sent to our front desk with instructions for scheduling the next appointment. If that patient needs follow-up with one of our care coordinators, because for our patients at risk, we often have touches after our appointments with our care coordinators. It's also sent to the care coordinators so they can do follow-up. Our experience with DoxyMe has been relatively easy. It's been very well accepted by our patients, and we've had staff that have had telehealth visits with our providers, and they almost universally rave about it. Initially, when we started, it was slow to respond, and that basically was because DoxyMe had literally hundreds of thousands of new users that they brought on board in this course of about 2 weeks. They've since worked through many of those issues. And at this point, upwards of 50% of our patients are being seen via telehealth. We're following a hybrid model, so the schedule is going to be a mix of telehealth visits and then in-person visits right now. One of the other advantages of the telehealth is that we have a number of providers who fall into the high-risk categories, and so they've gone to almost exclusively telehealth visits, and they're actually working from home at this point. So we're keeping them out of harm's way, hopefully, and hopefully we're keeping our patients out of harm's way by not coming into a health center where they could be at risk for exposure. So that's kind of it.
Doug, thank you for that experience from your health center. That's great information. There were a number of questions on the chat, and you did answer a number of them already for those that did put into the chat. But one question is, Doug, are you guys using the free version of DoxyMe or the professional version?
We decided to go for the professional version because of that features such as the virtual office, which includes the waiting room. It also allows our IT department to change settings across all our providers. If we'd gone for the free version, we wouldn't have been able to have that. The version that we have is costing us $50 per provider per month. So the cost is not that big. And we wanted that flexibility and to really make it feel like an office. So we're almost doing everything that we would do in a regular office visit, and we have a waiting room, a virtual waiting room, if you will. And so we decided the money was worth it.
Great, thank you. And one additional question, although there were a lot more in the chat. Are the providers documenting in near real time in
Yes.
the EMR when they're having either the telephone visit or the video visit?
It takes a little practice because you're using the screen for the virtual visit with the video, but then that same screen is also where your EHR is. And so toggling back and forth, that was a bit of a learning curve. We've given them initially a little more time to complete the telehealth visits because it's a new way of doing things. But all our visits are getting done pretty quickly, and they're staying on top of it. So some are able to toggle back and forth pretty easily. Those who are a little more challenged are doing more of their documentation right after the video visit is over.
Great. Thanks, Doug, and thanks for sharing your experience at your health center.
Okay.
Great. Now we're going to move to our next health center, which is Legacy Health in Houston, Texas. And Becky is going to walk us through her experience at Legacy. So, Becky?
Hello.
Good afternoon.
We can go. Good afternoon, all. So I'm Becky Jenks calling from Legacy Community Health in Houston. Like Doug stated, we're all building the plane as we're flying it. So I'm hoping I'll have some experience to share with you all. I'll try to focus a little bit on the technical aspect rather than the clinical. Can I have the next slide, please? So I sort of modeled this over the request regarding the summary point. So just a very brief layout of our patient care decisions. So week one, for many of you as well, was March 16th. We began with our behavioral health visits in a mix of traditional and telemedicine. So we still had patients coming on site as well as some call-in for the Zoom platform. Our COVID-19 testing is managed primarily in a tent setting at that point, which was utilizing some paper documentation and was not using telehealth at that time. For week 2, we expanded to include our family practice, pediatric, and OB departments. At this time, we're not including our dental and vision department. And again, maintaining a mix of traditional in-person visits as well as telemedicine, and continued with our COVID-19 testing to be managed primarily in the tent setting with some ability for patients to go through our regular lab system in the clinic with implemented screening prior to patients actually entering into the clinic doors to review the recommended CDC symptom checklist. Week 3, and it seems like it's crazy, it's just this week, we've expanded to include a fully virtual pediatric clinic that we've used staff, especially from our school-based health clinics, because all the schools are closed, stationed at multiple sites where we can actually do and kind of triage people from a virtual waiting room to these users. Another innovation that we've done for this week is for our PrAC program to reduce clinic foot traffic, is to allow our patient educators and testing at more of a non-traditional clinic site to work with the patient to connect them with the provider at one of our clinical sites so we can maintain their prep visits. And at this point, we shifted from the tent model to actually doing more of the COVID-19 testing in clinic with some level of phone triage, and then a setup outside the clinic doors where they are reviewing patients for symptoms and then moving through the clinic as needed. For next week, we're actually looking to expand to have some providers working fully from home. At this point, unlike what Doug was just discussing, everyone is on site doing those visits, but we're going to look to actually having staff working straight from home. Next slide, please. So our platform that we utilized was Zoom Telehealth with a telemedicine BAA to basically turn off functions such as recording and more ability to control the privacy. And we implemented it on March 16th. So our team is currently utilizing their standard issue laptops, which they use currently in clinic. Those laptops have integrated cameras, and on site, they're using just the regular office phones to call, but what we're looking to shift at for on-home is the Cisco Jabber system. We actually can link that in so when the patients are called from the provider's home, it doesn't expose any of their personal information. At one point, we considered utilizing iPads and dual monitors, but the clinicians actually found it was easier just to use the integrated video with picture-in-picture in Zoom so that they could document in centricity and at the same time see the patient. We did experience some pain points with audio due to certain headsets not working appropriately to be able to both speak and to hear. So as many of you probably experienced on your IT side, headsets are sold out all over the place, and that's still an issue that we're working through. And I'd say we're also trying to better utilize our patient portal for communicating with patients at this time. Next slide, please. So for our resource management, our IT optimization team sort of mobilized on the 16th to implement it with the medical director for behavioral health and essentially the operational site leadership. And we took a lot of ad hoc input and review from our compliance department, our billing department, and clinical department. So we quickly realized that advice from our chief legal officer and our billing senior VP was critical to make decisions moving forward with all the workflow decisions we were making. We've currently sourced our medical assistants to call the patients to offer them telemedicine visits and schedule appointments in Zoom. We're looking to expand that to our contact center reps in the near future as people get more familiar and comfortable with the technology. Right now, support a combination of the IT team managing the Zoom setup and some internal user support. And then our operational team is really managing workflow support on site. And we rolled out this week a dedicated contact center rep for patient assistance. So when patients are having difficulty connecting, we can actually give them direct support. Next slide, please. On the support side, we created a toolkit that we call our Telemedicine Toolkit, which is a PDF that has links to FAQs that we've developed, as well as workflow documentations. And we posted it on the SharePoint, and then we share that with any users as sites are being rolled out. Originally, we attempted to do individual training site by site. That became very difficult with sort of the shifting teams from site to site. So we really began doing video trainings with Zoom and virtual training as needed in order to keep up with the demand. We determined, and I highly recommend if anyone else goes live, I wish we had started this sooner, but it is a daily check-in with all relevant stakeholders via phone. It doesn't have to be an incredibly long meeting, but it's very helpful because things shift so quickly. It can be difficult to keep up with what's going on. And I'm sure many of you, our email inboxes are getting massive at this time. I also think it's been very helpful to receive a daily update from our CMO that goes to the entire agency in the afternoon. And that looks at not only the agency response to the COVID-19 situation and HR-related aspects, but it also includes any of the telemedicine rollouts and links to the toolkit and other core documents. So that's been very helpful to kind of bring everyone together as a team. On the billing and coding side, our billing and coding recommendations are provided by our Senior VP of Business Services, Melissa Garcia. And she is speaking directly with state and federal representatives, looking at CMS advice documents, and then, of course, direct contact with the local MCOs. And that is a challenge to work with so many different agencies to find directives. Currently, Legacy is only considering video visits as billable per the state of Texas, but we're continually negotiating on a routine basis to have more success in billing our telephonic visits. Legacy is utilizing Modifier 95 with the traditional E&M codes alongside some telemedicine-specific behavioral health CPTs, and we're actually requesting patient payment through portal message, as well as doing some patient registration to maintain demographics as well. Next slide, please. So finally, I just threw some pain points out there because I would love anyone else's suggestions. So I know we're struggling right now with, and for anyone that's looking for help, is how we manage documents and signatures without an implemented e-signature solution. So that's your disability paperwork, school paperwork, things like that. How do we move that back and forth with the patient? How to manage new patient registration and renewals. It was easier to do the established patients for the telemedicine, but the realities of getting new patients registered and our obligations as an FQHC is difficult. We're also working towards empowering our users to feel confident in using this technology with no support staff on site if they're going to home situation. Many users are used to having their colleagues or medical assistants assisting, and we anticipate we'll have to provide a higher level of support. And I think we're also struggling with managing telemedicine patients that may require an in-person visit. So that has come up with our pediatric virtual clinic, where they may appear at face that we could have a telemedicine visit, but in the case of perhaps like a newborn where a fever is at a certain level, when we need to actually move them to an on-site visit. And then finally, anyone else using Zoom delegates and licensing, I would love to share with some people about how we can make that an easier solution. So that's all I had for our slides. I'm open to any questions.
Great. Thank you very much, Becky. This is very informative and very helpful. Do you have one comment and then one question that did come in? The comment is that both Alliance Chicago and Health Choice Network will be working to negotiate with some of these vendors, specifically with Zoom and with DoxyMe on some pricing. So more to come on that over the next week or two. And the question came in from my colleague in Chicago, Dr. Stephanie Cox. How are you documenting vital signs in a televisit, in an e-visit, if you are?
So currently and I'm just speaking from what I know from speaking to the providers, we're still working through that process. So they're having the patients take a certain level of vitals, and I think they're erring on the side of abundant caution if there's any chance that, like, say, a temperature was higher than we anticipated. I was actually looking at using the patient-reported vitals form that exists in Centricity, but that actually doesn't include temperature or weight. So I'm open to suggestions if anyone else is using a different form. I would love to hear about it, but that's how we're handling it at the moment, since patients don't necessarily have I wish we had implemented all that cool interconnected home health stuff for our patients.
Great. And Doug, I was wondering if you're still on the line. Family Health of New York, are you collecting any patient-reported vitals from home?
We are getting that to some degree. There's some limitations to that depending on the patient. We've, over the last several years, we've kind of emphasized, particularly with our folks with hypertension, home blood pressure monitoring. So a good number of people have those, but then there are certainly those who do not. And then we're sort of, that's a gap in our care right now. And we haven't figured out a workaround entirely.
Okay. For those of you using Alliance Chicago content and soon with Intergen Health Choice Network, there will be some communication coming out later today for Centricity users to have content for additional screening for patient-reported fields for vitals. So more to come on that. So Becky, I want to thank you very much for your report on what's going on at Legacy with us, and I'm sure we'll be reaching out to you again. So our next health center that we're going to highlight is Heartland Health Centers, and we have two speakers who are presenting on Heartland that is in Chicago, Illinois. So Stephanie and Valentine.
Hi, this is Valentine. Can you all hear me?
Yes, we can.
Okay, thank you. So my name is Valentine. I am the Manager of Practice Transformation here at Heartland, and with me is Stephanie Blagich, who is usually working in our schools as a School Relations and Quality Coordinator. And we're going to be talking specifically about Microsoft products and telehealth. So this presentation is going to be geared more specifically to the technology that Microsoft and a lot of us already have access to, which I think complements some of these other presentations we've seen already from our colleagues who are using Zoom or DoxyMe. It's going to be more focused on the actual technology. I do want to say that we also, like some of our colleagues that presented, have split hybrid sessions where we are doing in-person visits when absolutely necessary, but we are also dedicating specific sessions for telehealth visits. So kind of to get us started with Microsoft Teams, which is our platform that we decided to go to, I wanted to talk a little bit about what we were looking for and why we ultimately decided going with Teams. So what we really needed was, as other people have mentioned, just a simple way to connect with patients. We also wanted it to fit with our current scheduling process. So we were looking for things that would add kind of minimal work or additional work to our staff, specifically our schedulers and also our providers for getting connected. And also we wanted something quick and affordable to launch, just as many have mentioned. Teams ultimately is integrated with something that we already use. This is, I believe, I'm going to be talking, or Stephanie will be talking about our scheduling process, which is available with the E3 Enterprise version of Microsoft 365. And it's something that our staff was already familiar with, so it was something that launching it was not going to take a lot of time, although a lot of training definitely is needed. It also had a really good system for reminding patients and educating patients, which I think is one of the struggles that all of us have gone through, is how do we educate patients on how to connect. One thing that's unique to our patient population, and maybe it's similar to all of you, is that a lot of our patients connect via cell phones. So the software is something that they can access via Android and iOS, and it seems like we're getting a great number of them that are connecting via their smartphones versus their computers. On the right here, you can see kind of a screenshot. So when a patient connects via Microsoft Teams, they will be prompted by this message to connect to the screen. They input basically their first name and just click join now. Stephanie's going to get a little bit into like how the scheduling process works for us and why it was the most beneficial system for us. And then we'll also be talking about the patient experience and kind of what some of the barriers and next steps are for us as well. So Stephanie, you can take this portion.
All right, thank you, Val. This is Stephanie. Can everyone hear me?
Yes, we can hear you, Stephanie.
All right, wonderful. So as Val was saying, here at Heartland Health Centers, we've opted for our Microsoft Teams and Microsoft Bookings in order to schedule our telehealth video appointments. So to reiterate, at Heartland, we are doing telehealth phone visits as well as telehealth video visits to maximize our accessibility with our patients. For the telehealth phone visits, we're booking in our EMR. For our booking visits, we're also booking them in our EMR with the addition of booking through this Microsoft Bookings application that you can see on the screen. The reason we are using this additional application is so that it can connect with a Microsoft Teams invitation for the patient and the provider to join. So on this screen is a sample of the booking page for one of our community clinics. So the person who is doing the booking will select a 15-minute, a 20-minute, or a 30-minute telehealth video visit, the date of the visit, a drop-down for the provider, as well as the time. And all of these times, because we are using a Microsoft application, our professional emails for Heartland Health Centers are also connected. So if a provider has various meetings or anything external to seeing patients, we will know that via the time so that we don't accidentally double book a patient when a provider has a previous commitment. So that is really a wonderful opportunity so that we can maximize our provider's availability as well. So once we select the visit time, the date, the provider, and then the time, then it becomes time to add the details about the patient. So on the right-hand panel, you can see Val's name and email address and phone number. That would be the patient's information. Once we enter that information, one of the downsides to this video bookings is that someone has to have an email address. A patient has to have an email address in order to access the video appointment. With that, once the appointment is booked, they will receive a confirmation email with a link to join Microsoft Teams. So that's why the email address is mandatory. We opted to have the phone number. The phone number can be optional. We've opted to have it mandatory as well, just for the sake of patient reminders. So once the patient information is entered under the details, the name, the email, and the phone number, and the appointment is booked, that instantaneously will send a confirmation email to the patient with the link to join Teams meeting. So Microsoft Booking in combination with Microsoft Teams, which Val has already said is something that our staff and our organization is very familiar with, and this is what the patient experience will look like. So this is the confirmation email that they get, the test or the confirmed booking for the patient, the visit with the provider, the date, the time, and then this all-important link right here that says join Teams meeting. So for our frontline staff who are booking a lot of these appointments, that is the instructions that we are giving to the patient, is once we book that appointment, at the time of their appointment, clicking the join Teams meeting link. We also are providing additional information to patients with numbers to the clinics and if they want to reschedule or cancel their appointment, as well as a guide specifically to patients on how to access their meeting. I know we are continuing to troubleshoot various patient experiences, wanting to make sure that our access is an access for all. But the nice thing about Microsoft Teams is that the patient and the provider is able to have that visual experience. Besides this confirmation email that is sent to the patient at the time of booking, Bookings gives us the capability to send out reminder emails. We've chosen 1 week, 3 days, and 30 minutes before their appointment to remind the patient of their appointment and provide that link and additional instructions multiple times with the hope that multiple viewings will make the process easier. And ultimately, it's a fairly easy process for the patient, meaning a one-click access to just join Teams meeting. So that is our booking experience. I'm going to turn it back over to Val to finish off some of our coming soons.
Thank you so much, Stephanie. And kind of to wrap up this portion, the right software is really just the start. So the number one barrier we have right now is connecting the time of visit. So even though they have a link to easily access and jump into the meeting, it still is limited to the browser that they use. So they would have to use either Google Chrome or Microsoft Edge. On the phone, it's a little bit easier once they have the application loaded because they would click in and they're already in the meeting as well. But given that this is so new to, I would say, a lot of people, including our own staff, sometimes there's difficulty if they accidentally click the mute button or the show webcam button on getting connected. So just as believe the first center that presented, we are also leveraging our medical assistants to help us connect 5 to 10 minutes before the visit to ensure that the patients are up in the meeting room or lobby before the provider accesses the meeting. And this kind of flows nicely into our kind of inpatient rooming process, where the patient is still able to talk to their MA, have them connect to their visit, and also what we didn't show here is kind of a checklist that we include in our EMR forms so that we can work through and provide, make sure that we are covering consent and everything that is required to bill appropriately for these visits. So connecting the time of visit with our MAs is the way that we're leveraging that. We also need a lot more patient education. So we are able to add hyperlinks in that to the patient confirmation emails and reminders, which is great. And just creating the material itself has been a struggle, while also troubleshooting some of the issues that have come up with our staff. And then lastly, phone visits are just easier to do. Everyone is so much used to connecting to phones, including our patients, and having high levels of low health literacy kind of makes it sometimes challenging to connect via video and these technologies, even though we acknowledge that it's a much more rich experience. So sometimes convincing staff and patients that phone visits, while easier to have, might not be the best way to have an office visit is challenging, and we're working to decrease these barriers to encourage more video visits as well. Things that have to be changed as the result of these are kind of the infrastructure that supports this. So bidirectional communication is a challenge. We are also trying to leverage our patient portal system. In terms of patient registration, we're pursuing also ways to electronically receive and sign documents. And then our payment services, right now, we mostly take payments over the phone, and we're looking to see if there's ways to modernize that process as well. And that's the end of our presentation. Happy to take any questions if time allows.
Yeah, so this is Tim. There is a couple of questions that came through for Heartland Health Centers, and a couple of them came from our colleague, Dr. Caroline Day in St. Louis. What percentage of patients are able to do Microsoft Teams audio video visits versus, let's say, maybe just a telephone visit?
So right now, I would say that our telephone visits are overwhelmingly great. Probably 8 out of 10 or 9 out of 10 are happening. We just launched this as of 1 week ago. But we just pulled data this Monday morning for last week's visits, and there is a trend happening where video visits are increasing. So we would like to see that number increase a lot more.
Great. And one more question. With Microsoft Teams, we believe that the provider has to send out an email. Are providers bothered by sending out their email to patients and then subsequently have patients contact the provider back using that email?
Thank you so much. That's a great question. Oh, sorry, Stephanie, you can answer that.
No, absolutely. No, that's a great question and something that we thought heavily about as we were developing this infrastructure. So the nice thing about the bookings application is that when we created the booking pages for the site and confirmations are being sent out to the patient, the response is coming from the site specifically. So the sender is Heartland Health Centers Albany Park, as opposed to specific for providers. So we definitely wanted to keep the privacy of the provider's specific email addresses as such. And so that's one of the reasons why we settled on bookings, so that the email is sent from a system and not a specific email address. Val, if you want to add anything.
Yeah, and bookings is accessed by our schedulers, so our care coordinators or frontline staff. The provider doesn't actually have to do anything except at the time of their visit, which is indicated in our EMR that it's a video visit. They know to look in their Outlook calendar and just hit the Join Teams meeting, which they're used to from just having meetings here at Heartland that way.
Great. Well, thank you very much, Heartland Health Centers teams, for that presentation and also the answer to the questions. So next, we're going to turn it a little bit and looking forward. So our colleagues at Finger Lakes in New York have done a lot of work on telehealth long before this COVID episode. So hopefully they can help us look at ways in which we can sustain telehealth operations beyond this COVID-19 period. So I'm going to turn it over to our colleagues at Finger Lakes.
Hi, everybody. This is Mary Zelazny, and I have Serene Garcia, my teammate, is going to help me with this. We've been doing telehealth for quite a long time. We got started in about 2006, 2007, mainly because we were trying to figure out a way to get our patients we're in a very rural area of New York State, trying to get our patients to specialty care. And a lot of our patients at the time were farm workers, and of course they had a lot of barriers, including transportation, interpretation, et cetera. So we saw very early on that technology was going to be the best way for us to try to mitigate some of those issues that they faced on a daily basis. So we started building our telehealth work through reaching out to specialty care providers and trying to get them engaged and say, listen, we need to send our patients to you. We'll help you understand how to use telehealth. We'll give you a piece of equipment to use, but we need access to you because we can't get our patients to you. So we built that program, and it's been highly successful. It has increased our quality metrics. Our patients have good outcomes because now they come in, instead of deciding whether they're going to see their primary care provider or their HIV provider, now they can see their primary care provider and then right after that see their HIV provider that's up in the urban centers. So we do all kinds of specialties now that come into our health centers, peds neuro, teledentistry, HIV, hep C, transgender hormonal therapy and mental health stuff, etc. But then we moved into primary care because we needed access to our providers and we didn't have a huge workforce to work from. So it was a way for us to take for instance, our bilingual diet nutritionist and spread her over our 8 health center sites. It was a way for us to spread our behavioral health providers across all of our sites. And our patients were very receptive to it. And so we continued to build and had some pushback and stuff, but then we've been jumping into direct to consumer where our providers can reach out to our patients. And in New York State, we just got the ability to bill for patients that are at home if the providers at the health center. And so we were going down that road and then COVID hit. And so now the beauty of where we are now is that we've been able to convert on a dime to do televisits to our patients because they can't get to us, don't want to get to us, etc. And so I'm going to have Serene just talk a little bit more in detail for you about some of the things that we're trying to do as we build this whole model to make sure that whatever we're doing now is going to sustain through the COVID pandemic, and keep moving forward, because this will change our lives as we see healthcare. It's going to change all of us, and we want to make sure that we're in the right place for that. So, Serene, you want to jump in?
Sure. Thank you, Mary. So from the get-go, early on, when we were working with the tertiary care providers, this was like 10 years ago, we really wanted to replicate what is being done in person. We didn't want to cut corners. We wanted to make sure that the quality of the care that was being done is exactly like if the patient was in the health center. Very similar to Doug's process that he talked about. We really want to make sure that our patients are able to get everything needed. So for us, being a federally qualified health center, it meant that we had to spend time with that tertiary care provider to see what it was that they were doing, figuring out how do they fill out their intake paperwork, talking about lab works and other pieces that are needed that are more in the urban area, and then bringing them into our rural communities. So early on for us, it was really identifying what was needed in that rural community to be able to replicate the service that is normally done in the urban setting. So one piece that we found was the lab offices. Some of the specialty lab work isn't normally seen in our rural lab offices. So having conversations with them and ensuring that the we had the proper billing processes, and that ensuring the lab offices that they were going to get reimbursed for their lab work that is being done, because those labs weren't traditionally seen there. Spending time with our staff and the distant provider to ensure that both were trained, building relationships and ensuring that one person knew what the other person was doing, or the other groups were doing, was important. So that care management, that care coordination work that's done in the background for appointment management, or even transportation into our health centers was very important to ensure that the outcome of the appointment was successful. Internally, same thing, same process. Again, it's replicating what is normally done in our health centers, because we found early on that we don't want to have our staff going off in a totally separate direction when they are normally have a already established workflow. We wanted to really just integrate telemedicine into our current workflow and have it be sustainable and have it just be adapted into the normal day-to-day life. So if you were to walk into our health centers today, there's video conferencing equipment in every exam room, whether it's medical, dental, or behavioral health. The equipment can be used for more than video conferencing. Our providers can use it's a computer, so the providers can use it for getting online and showing links to patients to address anxiety, or if they wanted to share resources that our patients can use, they can do that. They can bring in a third-party person if they need interpretation or need another provider to look at something with the patient. They can do that as well. We really want to integrate behavioral health into our primary care. So if a primary care provider is seeing a patient and then they identified that an intervention needs to be done, they can use the technology and call a colleague from another site and be able to use the resources there and connect the patient, do that soft handoff through a virtual visit, and then the provider can move on to another consultation. So it really is integrating and weaving our telemedicine process into our already established platforms or systems that we have. Another piece I think that's important to note is having dedicated support in ensuring that ensuring our staff that even though we're asking them to do business differently, doing work that's traditionally done and in person and now having it done virtually requires some hand holding, requires some reassurance, some relationship building within staff, and having that IT support readily available to help with training, help build the staff up and have them feel comfortable in case something goes down. Now with that, it really, for us, it means from the minute that we are looking for a new employee, during the interview process, we use video conferencing to do that first touch with that potential employee. During the onboarding process, we do training and talk heavily about video conferencing, because even if you're not a provider, we use video conferencing for general business life. So it is expected that every person in our organization feel comfortable with video conferencing, whatever platform that may look like or be, and whether it's for business or for patient care. So we set that tone early on when we have staff coming in new to say, this is the way we do business, this is how it's done here, and the expectation is that everybody is going to be able to know how they can connect and support each other. A ripple effect that has helped with this, it has really, for us early on, it has helped us to really leverage our workforce. So we are in upstate rural New York, but as staff have moved to other states or have found that their spouses move or whatnot, and they go with the family life requires them to move, we have been able to retain that staff. So we have people in other states and they're answering the phone as if they were in the same building. They are able to look at a document, quote unquote, over my shoulder by sharing the screen. So even there's ripple effects of changing the way we do business in our health centers, not only for our clinical folks, but also for our administrative support staff to be able to leverage the technology to keep workforce or add workforce from other areas. So with COVID, when we had to disperse staff and have most folks work remotely from home, it was a very easy transition for us. Our supervisors and managers were very comfortable with being able to have their staff work remotely. So it's really changing how we are potentially going to do business in the future because of the ease of being able to give more flexibility. Mary, do you want to talk a little bit more about that?
Yeah, I think that one of the key lessons that we've learned through all of our telehealth work is that, you know, it's the bottom line as we try to build it in our organizations. And frankly, it is critical, even before COVID, it is critical that FQHCs adopt and implement telehealth technologies, because this is the way that our patients are going to want to receive their health care, right? And COVID has just really changed how we all have to address health care, and it's forcing us to do things that we were all taking a really long time potentially to do. But this is how it's going to move going forward. So one of the things that we've learned is that whatever you implement today, you want to make sure that it's something that you can do moving forward. So one of the things, of course, CMS came out and said, okay, we're going to kind of relax HIPAA. And I said to my team, we are not relaxing HIPAA. We want our team to be consistent in how they do things, because if I keep changing the rules, someone's going to mess up and we're going to get a HIPAA violation. So however you build your telehealth technologies, even today as you do this through COVID, through the COVID pandemic, I shouldn't call it an epidemic, just keep in mind that you want to be consistent and you want to do things so that long-term your staff gets very comfortable with it. You know, our team was able to change so quickly because we've been drilling it into their heads for years, telehealth, telehealth, telehealth. And so it was pretty natural for them. And even couple of my providers that were holdouts jumped in and said, listen, we want to use WhatsApp or some other app to do telehealth because I think it'll be easier. And we said, no, if we're going to do telehealth because now we have to with our patients, and you're going to use the platform that we have and that everybody else is used to. So because we want them to do this moving forward. And I think that's the biggest lesson that we can impart to people, but that, you know, it's all about, for us, we've learned that it's all about change management. It's not about technology. It's about change management in the way that our staff provides healthcare and the way that we're used to providing healthcare, and trying to meet the needs of our patients going forward. That's what this is all about. And technology just gives us that nice little tool in our toolbox to be able to meet those needs. But just be consistent and just think, long term as you start planning a lot of things. You don't want to be too impetuous. So with that, I would say thank you.
Great. I want to thank you both so much for that insight. And you guys truly have been national leaders at Finger Lakes, and we really will be tapping on your expertise in the coming weeks and months. I did have two questions for you that came through the chat. One question, a lot of people were asking what platform you're using. And then the second question is, how are you utilizing telehealth for an oral health visit, and what does that look like?
Okay, I'll talk quickly about oral health, and then Serene, you can jump to the platform question. So we use teledentistry. We've built a program since 2010 where we have a big school-based dental program, and we go out twice a year to the schools and the daycares and Head Start sites. And what was happening is all these little kids, we kept seeing them over and over again. We would refer them up to the pediatric specialist up in Rochester, which is the big urban center that takes Medicaid and Child Health Plus, because these kids were like 5 years old and needed root canals, and we just weren't able to do that at our health centers. So we built a program with them where we would be able to do the consult with a kid at our health center, or even at the daycare or the school where the kid was, with the specialist up in Rochester with an intraoral camera. And then also the parent could be there if they wanted to be. And through a whole lot of work, what ended up happening is we went from a 15% success rate of getting those kids their treatments done because they couldn't get up to Rochester. They didn't have insurance to get there. They had a lot of barriers. And so we were able to, through using technology and care management, we went from a 15% success rate of those kids getting finished, their treatment finished, to about 95% success rate on those kids. We pulled back a little bit on the care management, and we immediately dropped down to about an 88% success rate. So we've jacked that up again, but it's a great program. It's also really great for inpatient or for like people that are in substance use treatment centers, ARC, developmental disability homes, et cetera, where a dentist can go in virtually and look at a problem without having to send the patient to emergency room. In this particular, in the pandemic, the problem is for our dentists is you can't, if a patient, you can do a visit, a virtual visit with a dentist if the patient's at home. The problem is you can't get a picture of the actual tooth unless you can stick your cell phone in your mouth somehow. And so it's not really as useful in this particular way. When we've been really trying to brainstorm it, but for our kids with pediatric dentistry, we've seen a little over 900 children and completed their treatment plans so far, and we have about 150 kids right now still, in the middle of it. So they're in process right now, and it's highly successful, that program for these kids. And Serene, you want to talk about the platforms?
Sure, yep. So we have a variety of different platforms. So early on, we started with Cisco Jabber from site to site. So we're able to have that be in our health centers, or using a specialty provider, we can have them get an account for the Jabber platform. Today, for the direct to consumer, we leverage our patient portal. We use DCW, and that has a patient portal with a waiting room that they can use. If patients don't have patient portal set up, we also are using Zoom, so because it's just easier to send them a link and be able to connect with the patient, and then go through the process of getting them up in the patient portal. So we use 3 different processes right now. Again, we want to meet the patient where they're at. We try to encourage our patients to get on the patient portal, but for whatever reason, if they are unable to, we give them other options to be able to connect.
Great. Well, I want to thank you guys so much for that valuable information. And I'm sure we'll be tapping your expertise soon, actually. So next, we're going to turn over to our Health Choice Network and Alliance Chicago experts on COVID-19 resources. And here we have 2 RNs who have put together some valuable resources for all of our health centers, irrespective of what EMR you're using. So first, I'm going to turn it over to Julian, who is going to walk us through some guides that she and her team have put together, and then we'll hear from Jen from Alliance Chicago.
Thank you very much, Dr. Long. Good afternoon, everyone. My name is Jillian Javed, and I've been with Health Choice Network for over 3 years as a clinical informatics specialist on our system optimization team. Today, I'm going to take just a few minutes to talk about some of the newly developed resources. We understand that during this time, each and every organization has a unique telehealth need, and those needs require individual software solutions. So to help during this time of rapid adoption, we've selected the most commonly used platforms, which include Zoom, WhatsApp, and Doxy.me, and created user guides to help patients, clinicians, and the support staff walk through the processes needed to navigate the new systems. These processes include topics like downloading or creating an account when needed, creating or scheduling a virtual visit, and launching that virtual visit at the time of the appointment. These 1 to 2 page guides can be easily distributed to patients and staff using methods like the patient portal, email, or even adding them to your website so they can get those directly. Next slide. To access these resources, start by navigating to the Health Choice Network homepage at www.hcnetwork.org. Click the COVID-19 Resource Library link in the upper right-hand corner. then select Telehealth Resources, and then Telehealth Software User Guides. Next slide. Here's a quick example of one of the user guides that's designed to help a patient download the Zoom app and then join a Zoom meeting from their iPhone. As you can see, the guide provides step-by-step instructions along with screenshots to try and make the process as smooth as possible for the patient. So with that being said, I am going to thank everyone for your time and hand it over to Jen so she can share some additional resources.
Great, thanks everybody. So a quick rundown of both the 1135 waiver and the existing free telehealth expert resources that are available to you, particularly because these things vary by state and your Medicaid programs. So as a quick overview, the 1135 waiver. When the President declared the COVID-19 pandemic as a national emergency on March 13th, the Secretary of the Department of Health and Human Services, or HHS, invoked his authority to temporarily waive or modify certain Medicare, Medicaid, and Children's Health Insurance Program, otherwise known as CHIP requirements, to ensure that sufficient healthcare items and services are available to meet the needs of individuals enrolled in these programs, and the providers who provide these services in good faith can be reimbursed and exempted from sanctions. So this authority is provided to the Secretary under the Section 1135 of the Social Security Act, where all these programs fall under, and that is why this is called the 1135 waiver. For some of you, depending on where you live, this may sound very familiar because you tend to naturally be in an area where there's a lot of natural calamities or disaster related to weather. And some other parts of the country, this may be very new because this is only invoked when there is a national emergency declared. So the Secretary's authority took effect on March 15th with a retroactive effective date of March 1st of 2020. So the emergency period will terminate and waivers will no longer be available upon the termination of the public health emergency, including any extensions. Why is the 1135 waiver important, particularly for the states, particularly for the Medicaid program, is that because in this waiver, there's a disaster-related legal authorities that include provision of services in alternate settings. Now, this provision is in there along with 16 other provisions that the state Medicaid programs could have submitted to apply to get waivers for. Most, but not all states opted to include this in their waiver. So even though the waiver approval letter from CMS looks very similar, I do encourage each of you, depending on the state that you live, once you get these slides, click on that link to make sure that this is a provision within the 1135 waiver for your state. As of yesterday, March 30th, 12 p.m. Central Time, 37 states and Puerto Rico have been approved for this waiver. And when I looked this morning, they were continuing to approve these waivers. I think 4 other states are included as having an approved 1135 waiver. This is really important because that provision about the services in alternate settings, again, depending on what telehealth looks like for your Medicaid program in your state, allows the providers to provide services in alternate settings, meaning including an unlicensed facility, and they're still covered. So if the provider's licensed facility, like your health centers, are closed down for whatever reason, you have set up shop on your parking lot, you have tents, or they're working from home, this 1135 waiver, if your state submitted and got approved for it, covers the providers under this national emergency. So using existing free telehealth expert resources, these were around before this current situation, but the Center for Connected Health Policy, CCHP, they do an excellent job keeping pace with your state-specific action for COVID-19, specifically for telehealth. They maintain this for general telehealth and telemedicine, but specifically for COVID-19, they're doing a great job updating this. They also have a newsletter. So if you have somebody at your health centers who's in charge of compliance and regulatory requirements, make sure they sign up for the newsletter for CCHP because they are on a daily basis digesting the CARES Act. So what that means, who can you provide telehealth medicine services to? There's a lot of question about existing patients, new patients. They quickly digested and said that a lot of these provisions got adjusted. So you can now offer telehealth services to both existing and new patients. So please find somebody at your health center who can sort of keep pace and maintain current knowledge of what's going on with that CARES Act by subscribing to the CCHP newsletter. The second free resource that's available to everybody is the Telehealth Resource Center. These include telehealth quick start guides for primary care. So again, this is FQHC and RHC focused. So the primary care and the mental health focus that you see linked there will give you a fairly good, comprehensive, quick setup guide for telehealth if you haven't set it up. And even if you have set it up, I do encourage you to go through these slides because they do go through both the prerequisites for what you need, the policies, the procedures, the practice. So it covers everything that you want to know from technology to documentation to billing. Speaking of billing, so CPT codes and HCPCS codes, the necessary modifiers, again, this depends by state and Medicaid. Some people may be using the modifier of 95. Some other states it's going to be GT. Some other states it's going to be GQ. The key thing to put at the end of these CPT codes, the modifiers, is really the place of service for telehealth, which is 02. For the Alliance Health Centers who are currently using Centricity and Visualution's Athena Practice, please do look out for an email that's planned to go out today that gives you RCM best practices and how to set this up in Centricity. We are going to repurpose that for all the other states that are supported by Alliance Chicago and HCN to give you some best practice guidelines, particularly for the billing piece, which we know is consistently the question, like how are we going to get reimbursed for this? And also know you see those two logos down there, Alliance Chicago and HCN. Our staff is always available to you now more than ever to answer any questions, so please use your usual channels to contact us, and we will love to help you in any way that we can. That concludes the telehealth for COVID-19 state and Medicaid resources. Thank you.
Great, thank you, Jen, and thank you, Julian, for those great updates. We could have done a whole hour just on that, and we might in the future. So on the next slide are some resources. You can scan this using your phone, which will take you directly into Health Choice Network's resource library or Alliance Chicago's resource community loop. Both of these are a great wealth of information that we have been collecting since the beginning of the COVID pandemic. All of the slides will be available to all of the participants. There's a lot of information on the blue hyperlink, so please share these slides liberally with your staff. And lastly, we want to thank you for your time today, for joining us on preparing communities for COVID-19. This was our second series. We will be doing these weekly. Today's focus was on telehealth, and we might be doing some more on telehealth in the future. So please look forward to an email coming to you in the next 24 to 48 hours. We might have to change the time and date of next week. We do not want to conflict with any other national webinars that are going on with COVID-19, but we definitely want to make sure that both Health Choice Network and Alliance Chicago is providing you the most up-to-date information to help you, our healthcare heroes. We are very grateful for the work that each member of a healthcare team at a health center is doing for the community health center movement. So once again, thank you very much for joining our Health Choice Network and Alliance Chicago's Preparing Communities for COVID-19. I hope everybody has a wonderful day, and please keep a smile on your face because we will make it through this. I hope everybody has a great day. Bye.